Yeah, look, and certainly, everybody who's had a weight problem, who's had a little bit of weight regain or is struggling to maintain their weight, has a pretty reasonable desire to look for things that might aid them to lose more weight. I mean, could you blame them? The one issue we have, though, is that when we look at the outcomes from procedures to try to achieve weight loss in people who've had sleeves and bypasses, the weight loss results are actually not that flash. So if you reoperate on somebody who's had a sleeve or a bypass with an intention to lose weight, the average weight loss is closer to 10 to 15% rather than the initial 30 or 40%, because you're not performing a majorly transformative procedure. So when you're turning a sleeve to a bypass, you're turning a very small stomach into a slightly smaller stomach.
Yeah.
Yeah.
Makes sense.
If you're doing a pouch trim on a bypass, you're turning a very, very small stomach into a very, very, very small stomach. You might be reducing its volume by 20 or 30 cc's. Or if you're lengthening a bypass, you're going to be turning a small bowel bypass into a longer small bowel bypass to try to get a bit more of a metabolic effect. But the effects are always going to be relatively small. So while we do undertake weight loss revision surgery after sleeves and bypasses, it's similar to the reflux thing. You've got to ask yourself, what's leading to this person's problem? And will an operation fix the problem? Or how will an operation fix the problem? So if somebody's got an issue, for example, if they've had a gastric bypass and the old stomach and the new stomach have joined back together again, it's called a gastro-gastric fistula, then those patients will often regain weight. It's a very easy solution because you just divide the join between the new and the old stomach and you give them a new stomach back that's small and they're off on their way. But if somebody's got an anatomically correct small stomach after a bypass, then you have to look for other things you can do rather than surgery to try to get them to lose weight, which really just means how do we get them to use their bypass?
Yeah.
Great.
And and what we know these days is that because we've got so many more tools in our tool belt, that sometimes non-surgical therapies are a really good way to do things, or at least a very good way to start. Because if you've got a complex problem, why not use every single tool in your toolbox? Why just rely on one thing?
Yeah.
Yes.
Amazing.
I totally agree.
Do you get very many people that have sort of gone band to sleeve and then they're coming back for a bypass?
A reasonable number, and that's always a bit of a disappointment. The sleeve is a great operation. It really is very good, but it doesn't perform well in people who have had previous gastric bands. So yeah, if you do a bundle of sleeves on people, you'll find 90 to 95% of people are pretty happy with their outcome. And there's not that many people back for early reoperative surgery. When you do band to sleeve surgeries, you find that the early return for further surgery is about 20 or 30%. And there's a
Wow.
couple of things going on.
Yeah,
One
so
is that
why is that?
the average, the weight loss from a band to sleeve is closer to 20%. So rather than 30%. So if you're 150 kilograms and you have a sleeve, you might lose 50, you'll be pretty happy. If you're 105 kilograms, 95 kilograms, 110, who cares? You'll be okay.
Yeah.
But if you're 150 kilograms and you've had a band and then you have a sleeve, you'll probably be, not as good. You've lost 20%. You might lose 30 kilograms. You'll be 120 kilograms. If you're 120 kilograms, the problems that you had at 150 kilograms are still going to be there. also, because the band disrupts the function of the esophagus and the upper stomach, people are more prone to reflux. So the reflux rate is significantly higher, like
Wow.
enormously higher. So early reoperations for reflux after band to sleeves is very high.